Good morning, everyone, and welcome. I'm Dr. Asim Hussein, and I'm pleased to be here with you today. We'll be discussing endocrine and metabolic emergencies, focusing specifically on diabetic ketoacidosis, or DKA. In this presentation, we'll cover the key aspects of recognizing, managing, and understanding this critical condition. So let's get started and explore what you need to know about DKA to better serve your patients. Let's take a closer look at this table. It lists several types of acid-base disturbances, starting with hyperosmolar hyperglycemic state, then diabetic ketoacidosis, lactic acidosis, alcoholic ketoacidosis, and sepsis-induced acidosis. Each of these conditions has unique features, but also overlaps in presentation. Now, focusing on the question, we have a 35-year-old man with type 1 diabetes presenting with vomiting, polyuria, and cusmal breathing. His labs show a blood glucose of 19 mmol per liter, a pH of 7.23, bicarbonate of 14, and ketones at 5 mmol per liter. The key points here are the high blood glucose, the low pH indicating acidosis, the low bicarbonate, and the elevated ketones. These features strongly suggest a diabetic ketoacidosis, or DKA, which is common in type 1 diabetes. The cusmal breathing is a compensatory response to metabolic acidosis. Trying to blow off CO2 to raise the pH. Recognizing these signs helps us distinguish DKA from other causes of acidosis. So, in this case, the diagnosis is diabetic ketoacidosis, a critical complication that requires prompt management. All right, let's focus on what defines diabetic ketoacidosis, or DKA. The correct answer here is B. Now, to understand why, we need to look at the key diagnostic criteria. DKA typically presents with a blood glucose level greater than 11 mmol per liter, so that's quite high. Then there's the pH. It's usually less than 7.3, indicating acidosis. The bicarbonate level, or HCO3, drops below 15, reflecting the metabolic acidosis. And finally, ketones in the blood or urine are usually above 3. Showing significant ketone production. This set of findings actually fits the classic triad of DKA, which is important for diagnosis. Recognizing these parameters helps us quickly identify and treat DKA effectively. So, in summary, when you see these lab values, glucose over 11, pH below 7.3, bicarbonate under 15, and ketones over 3, you can confidently diagnose DKA. Let's look at the options for the initial management of this patient with diabetic ketoacidosis. The first step is crucial to stabilize her hemodynamics. Starting with an IV insulin bolus is important, but not the very first action in this scenario. Administering IV fluids, specifically 0.9% NaCl, immediately is actually the top priority here. Because she's tachycardic, hypotensive, and severely dehydrated, her main issue is volume depletion. Replacing her fluids promptly will help improve her blood pressure and tissue perfusion. While giving insulin is essential for correcting the hyperglycemia and ketoacidosis, it's typically done after initial fluid resuscitation. Giving bicarbonate or starting potassium infusion are important considerations later, but not the immediate first step in this acute setting. Switching to half-normal saline might come into play later once initial resuscitation is underway. So, in this case, the most important initial intervention is to give IV fluids immediately to restore her circulating volume and stabilize her condition. This step sets the foundation for further treatment, including insulin therapy. Let's take a closer look at the correct answer, which is B. When managing diabetic ketoacidosis, or DKA, the first and most crucial step is fluid resuscitation. This is essential because patients with DKA are usually severely dehydrated due to osmotic diuresis. The initial fluid of choice is typically 0.9% saline, and we usually start with about 1 liter in the first hour. This rapid fluid replacement helps restore circulating volume, improve tissue perfusion, and prepare the patient for further treatment, including insulin therapy. Remember, the priority here is to stabilize the patient's fluid status before addressing the hyperglycemia and ketosis with insulin. This step is fundamental in preventing complications and ensuring a safe and effective recovery process. let's look at this critical situation. We have a patient with diabetic ketoacidosis, and their potassium level is 3.1 mmol/L, which is quite low. The key here is understanding how to manage insulin and potassium safely. Starting insulin infusion immediately is usually the standard approach in DKA. But in this case, because the potassium is low, we have to be cautious. Administering insulin too quickly without correcting the potassium first can cause a dangerous drop in serum potassium, leading to cardiac arrhythmias. So, what's the best approach? We need to give potassium first to raise the level to a safer range before starting insulin. This prevents hypokalemia from worsening once insulin drives potassium into the cells. In this scenario, delaying insulin until we correct the potassium makes sense. Giving potassium first helps stabilize the patient's cardiac membrane potential. Once the potassium is at a safer level, say above 3.3 or 3.5 mmol/L, we can then start insulin infusion safely. Therefore, among the options, delaying insulin and administering potassium first is the most appropriate. It's a delicate balance, treating the acidosis while preventing hypokalemia-related complications. Remember, safety always comes first, and proper potassium management is essential before initiating insulin therapy in these cases. Correct answer. B. Now, let's talk about what to do when potassium levels are dangerously low. If the serum potassium, K+, is less than 3.3, we need to pause insulin therapy. The reason for this is that insulin can further lower potassium levels, which can be risky. Instead, we should give potassium first to correct the deficiency. This step is crucial because severe hypokalemia can lead to life-threatening arrhythmias. So the key takeaway here is that when potassium is below 3.3, stabilizing the potassium level takes priority before administering insulin. This approach helps prevent dangerous heart rhythms and keeps the patient safe. Remember, managing potassium properly is a critical part of controlling diabetic ketoacidosis effectively. In this scenario, we see that the patient's blood glucose has dropped significantly from 28 to 9 mmol/L within just 30 minutes after administering insulin and fluids. This rapid decline indicates that the insulin rate might be too high, leading to an overly aggressive correction of hyperglycemia. The key point here is that when blood glucose falls too quickly, it can increase the risk of cerebral edema and other complications. So, what's the appropriate adjustment? In this case, the most suitable step would be to stop fluids temporarily. This helps slow down the rate of glucose reduction and prevents overshooting into hypoglycemia. Adding dextrose to the IV fluids is also an option, but only if the blood glucose drops below a safe threshold, typically around 10 mmol/L, to maintain adequate glucose levels. Increasing the insulin rate further or giving mannitol immediately are not appropriate in this context. Mannitol is used for cerebral edema, but the primary concern here is controlling the rapid glucose decrease. Similarly, giving bicarbonate infusion is not indicated unless there's severe acidosis, which isn't specified here. Overall, the most important concept is to carefully monitor and adjust treatment to avoid rapid shifts in blood glucose, ensuring a safe and steady correction. Let's take a look at the correct answer, which is the key point here is that when managing blood glucose, the drop should be carefully controlled. Specifically, the blood glucose should decrease by no more than 3 to 4 millimoles per liter per hour. If the fall is too rapid, there's a significant risk of cerebral edema, which can be very dangerous. To prevent that, we add D5W, or 5% dextrose in water, to slow down the rate of glucose decline. This approach helps us safely correct hyperglycemia without causing harm to the brain. Remember, controlling the rate of blood glucose correction is crucial in these cases. All right, let's focus on understanding how we determine when diabetic ketoacidosis, or DKA, has resolved based on biochemical targets. On this slide, we see a table with different parameters labeled A through E, each representing specific lab values. Parameter A indicates glucose less than 11 mmol per liter, which shows blood sugar control, but isn't solely enough to confirm DKA resolution. Parameter B refers to ketone levels below 3 mmol per liter, suggesting ketosis is improving, but again, not the only factor. Parameter C combines pH greater than 7.3, HCO3, bicarbonate above 15, and ketones less than 0.6. This combination is key because it indicates that the blood is no longer acidotic, and ketosis has significantly subsided. Parameter D notes that potassium levels, K+, are normalized, which is important for electrolyte balance, but by itself, it doesn't confirm resolution of acidosis. Lastly, parameter E shows an anion gap less than 20, which reflects that the metabolic disturbance causing acidosis has been corrected. So, to answer the question, which of these biochemical targets indicates that DKA has resolved? The most reliable indicator is the one that shows the correction of acidosis and ketosis, which is parameter C when is above 7.3, bicarbonate exceeds 15, and ketones are below 0.6. It confirms that the metabolic derangements of DKA have been adequately reversed, signaling resolution. Remember, no single parameter tells the whole story, but together, these targets help us confirm when it's safe to move on from aggressive management. The correct answer here is C, and let's talk through why that is. When we're evaluating resolution criteria, there are a few key blood parameters we need to keep in mind. First, the pH should be greater than 7.3, indicating that the blood is returning to a more normal, less acidic state. Second, the bicarbonate level, or HCO3, should be above 15, which suggests that the body's buffering capacity is restoring. Lastly, ketone levels should be less than 0.6 mmol per liter, showing that ketosis is resolving. These thresholds are important because they help us determine whether the metabolic disturbance is improving and whether the patient is stabilizing. So, understanding these criteria is crucial for managing and monitoring treatment progress effectively. Let's go over the key diagnostic points for diabetic ketoacidosis. First, we look at glucose levels, which are typically greater than 11 mmol per liter. This indicates significant hyperglycemia. Next, the blood pH is usually less than 7.3, reflecting an acidic environment in the blood. Along with that, bicarbonate or HCO3 levels drop below 15, showing metabolic acidosis. We also check for ketones, which are usually above 3 mmol per liter, signifying that the body is producing excess ketones due to fat breakdown. When we combine these findings, high glucose, low pH, low bicarbonate, and elevated ketones, they point towards a specific type of metabolic disturbance called an anion gap metabolic acidosis. All these features together form the structured summary of diabetic ketoacidosis, or DKA. Recognizing these key points is crucial because they help us confirm the diagnosis quickly and accurately, guiding us toward urgent management. Remember, the hallmark here is the combination of hyperglycemia, acidosis, and ketonemia, which sets DKA apart from other diabetic emergencies. Let's now focus on the management priorities in treating diabetic ketoacidosis. First and foremost, fluids come first. We typically start with 0.9% saline at a rate of 1 liter per hour to correct dehydration and restore circulatory volume. Next, if the patient's potassium level is less than 3.3 mmol per liter, we need to correct the potassium before starting insulin therapy. This is crucial because insulin can drive potassium into cells and worsen hypokalemia, which can be dangerous. Once potassium levels are adequate, we proceed with insulin infusion at 0.1 units per kilogram per hour. It's important to note that we do not give a bolus dose of insulin, simply start the infusion steadily. As blood glucose begins to decline and drops below 14 mmol per liter, we add dextrose to the IV fluids. This helps prevent hypoglycemia while still allowing insulin to work and resolve ketosis. Finally, we must treat any underlying triggers of DKA, such as infections, missed insulin doses, or myocardial infarction. Addressing these triggers is essential to prevent recurrence and ensure comprehensive management. Overall, These steps form the core of how we manage DKA effectively and safely. Now, let's talk about some complications to watch out for during treatment. First, hypokalemia, or low potassium levels, can occur and needs careful monitoring because it can affect heart function and cause muscle weakness. Next, cerebral edema is a serious concern, especially if we drop blood glucose levels too quickly. Rapid changes can cause fluid to shift in the brain, leading to swelling, which is why gradual correction is essential. We also need to keep an eye on the risk of acute kidney injury, or AKI. Dehydration and shifts in fluid can impair kidney function, so hydration status is crucial. Hypoglycemia, or low blood sugar, is another potential complication if insulin therapy is not carefully managed. Finally, let's not forget diabetic ketoacidosis, or DKA, which is the primary condition we're managing here. It's important to understand that while we're correcting the metabolic disturbances, we must do so cautiously to avoid these complications. Overall, careful monitoring and a structured approach are key to ensuring safe and effective treatment. Thank you so much for your time and attention today. I really appreciate you being here and engaging with the material. I hope this presentation has provided you with valuable insights and practical ideas that you can take forward. Remember, the key points we've discussed are all about understanding the importance of collaboration, innovation, and continuous learning in achieving our goals. These concepts are at the heart of everything we do, and I encourage you to apply them in your own work. Once again, thank you for being part of this journey. I look forward to seeing how you implement these ideas moving forward.